Assalamu alaikum, everyone. Am I audible?
Yes.
Yes.
Yes, ma'am. Audible. Audible, ma'am.
Welcome to the Neurosurgical case room. Let's hope the internet treats us better today. Just give me a minute. Let me see if anyone is unmuted. Okay, so I really hope that all of you have reviewed yesterday's session and the day before yesterday's session, because we are not going to touch the actual anatomy and the orientation at all. Let's proceed with the AICA variations and its particular anatomy. So why are we discussing AICA and one other vessel in such detail? Because these sessions are our build-up for the retrosigmoid approach and the vestibular schwannoma. For that, you need a very good grip on the middle neurovascular complex and AICA, and there's one other vascular structure. We will come to it later on. So what was the middle neurovascular complex? Can somebody name the structures? Cranial 6, 7, 8, right? And AICA, middle cerebral peduncle, the pons. These are some structures that we need to remember when we are working in the CP angle and the retrosigmoid approach, especially. So when we talk about AICA can have variable anatomy. It can have a single trunk. It can have duplicate trunks in roughly around 26 to 30% of the subjects. Very rarely, it can have triplicate trunks as well, bifurcating very early on. In fact, trifurcating very early on as soon as it leaves the basilar artery. And sometimes what happens is, this is the basilar artery, we know this, and AICA is a branch, right? In the variations, sometimes labyrinthine artery can arise from the basilar artery directly. Sometimes we have a common trunk. Let me see, a common trunk for both the AICA and PICA. Usually PICA arises from, can somebody mention?
Vertebral artery.
That's right. Usually the PICA arises from the vertebral artery and the AICA arises from the basilar artery after both of the vertebral arteries have combined together to form a single trunk. But a very rare anatomical variation is when there's a single trunk arising from the basilar artery. That trunk has both the origins of AICA and PICA, and usually in these scenarios, PICA is hypoplastic. So this is an AICA dominant system. Now, why is this important for us? We want to know the neurovascular anatomy before we proceed for the surgical resection of any lesion, because God forbid, if you end up injuring any of these vessels, the neurological deficits are not pretty. What ends up happening is something that I have noticed in my personal experience. Even if, there is a deficit, a mishap around any neurovascular structure in the supratentorial compartment, it's a lot more forgiving. But when you're working with posterior fossa or the infratentorial compartment, it's a lot less forgiving in terms of any complications or any extra structures that you'd determined to sacrifice during the surgery. So keeping in mind that we want to be safe surgeons, right? This is our basilar trunk. Let me start my marking. This is our basilar trunk, basilar artery, and you can see the AICA, and you can also see the segments beautifully as well. Now, there are some segments which are not visible here. This is the metal AICA. Then we have the, let me see, just give me a minute. I labeled it wrong. So this is the premeatal AICA. This is the metal AICA. This one is postmetal. And these branches, if I continue them, these are the cortical branches or the cortical segment. I am audible, right?
Yes.
What we mean by metal is we are dividing the sections of AICA before, around, and after the internal acoustic meatus. So this is your internal auditory canal. This is your benchmark. The AICA before it is the premetal AICA. Then we have the metal AICA, which goes around it, sometimes makes a loop inside the internal auditory canal. Sometimes it stays outside, but this is the CPA angle cistern. And then it makes this turn, it comes out as the postmeatal AICA. And then this postmeatal AICA has these terminal branches, which are the cortical segments. Let me right here. This is our CPA angle cistern. Is that clear?
Yes.
Okay, let's look at some other images. In fact, let's do the anatomy first. We have the premeatal segment. It originates from the basilar, travels across the pons and around the cranial nerve 7 and 8 complex. The problem is sometimes it gives these small perforating branches to the pons that look very minimal on the examination, on the inspection, but they are not sacrificable. Then we have the meatal segment. The meatal segment is the one which is traveling around the CPA, right? Why is it important? It gives subarcuate artery and it also gives labyrinthine artery. Now, please remember that labyrinthine artery as an anatomical variation can directly arise from the basilar artery. In these cases, you will not find the labyrinthine artery arising from the AICA. So it's a good idea to get the preoperative imaging on your fingertips so that you know where to look for it. Labyrinthine artery is an end artery. You cannot sacrifice it. If you sacrifice it, what happens? Sudden onset? Deafness, right? I am audible.
Yes.
Okay.
Yes.
Okay. So what happens is
Yes, ma'am,
if
you're
you,
audible.
okay, if you end up sacrificing labyrinthine artery,
Audible.
assuming that it is a perforator to the tumor, or inadvertently while you are dissecting it off the tumor, patient is going to have sudden onset deafness. And even if you know you are 100% sure that you ended up saving the vestibulocochlear nerve postoperatively, this will be very difficult to explain. The postmeatal segment is after the internal acoustic canal. After the loop has been made, it comes out, it travels towards the cerebellopontine fissure, and then it ends up giving the cortical segment branches. Are we all on the same page till here?
Yes, ma'am.
Yes.
Okay. So apart from this, we want to be sure about the anatomical relationship of AICA with the cranial nerve 7 and 8. Let me... Okay, Dr. Subham is saying, Dr. Subham, that is very brave of you to accept a complication. That's very, very brave of you. But yes, it can happen to anybody. Labyrinthine artery at times can be very thinned out, hypoplastic. It can look hypoplastic. It can look very pale under the microscope and splayed over the tumor capsule. Easy to misrepresent it as, you know, a tumor perforator. And yes, the patient will develop sudden onset deafness, even if the vestibulocochlear nerve is intact. So I have included a chart at the end of this session for easier understanding of the anatomical relationships, but you need to know what is the most common position of AICA. Usually AICA passes below and behind the nerve complex. What does that mean? When I say below and behind, what does it mean if I am doing a retrosigmoid approach? If a structure is
inferior, and it will be the first
yeah,
prior to the nerves. It will be encountered before we encounter the nerve.
yeah. So once we open the patient via a retrosigmoid approach, once we travel the CP angle cistern, what are you going to see first? AICA would be visible, right? AICA would be, most of the times, AICA would be easily visible. Sometimes
AICA
you
will
might
be
see,
near to that choroid plexus, madam.
sorry?
AICA will be near to the choroid plexus.
Yes, but we
Uh,
are very far from the choroid plexus. We are in the CP angle cistern and we are discussing the retrosigmoid approach, right? So we have only retracted part of the cerebellar hemisphere very, very gently. There is a very small corridor that we are following. It's a natural corridor. What I wanted to ask was, once you open this space, AICA is going to be visible if the anatomy is your typical anatomy, because it is usually below and behind the nerve complex. While I say below and behind, you would want to remember this yellow structure is your facial nerve. This green structure is your vestibulocochlear nerve, which is hiding the facial nerve. And this is where the AICA would be, right? Below and behind. So if you remember, I made a very strong point of mentioning that once we are doing the retrosigmoid approach, the first nerve that we see is the vestibulocochlear nerve. Similarly, the vessel that we will see will be AICA. AICA will be visible until and unless the tumor is large enough that it is hiding it, or it has already branched. There are some variations, etc., etc. The common location of AICA is posterior inferior to the nerve complex. The other common location, which is slightly less common, it's anterior superior. It will be above and in front of the nerves. Then there is a variation which is interneural. What ends up happening is you have the facial nerve and you have the vestibulocochlear nerve, and AICA makes this loop in between them. Is that clear?
Yes. Yes.
So what ends up
Yeah.
happening is now your vessel, a vessel that you cannot sacrifice in any case, is traveling between two of the nerves, one of which is carrying the tumor. What does this do? This puts this artery as a very high risk structure that you can injure, even if you are trying to preserve it and play as safe as you can. So interneural variation of AICA, interneural loop, is something you should know beforehand. How would you know? You would need a FISTA sequence preoperatively to study the anatomy of AICA and to be sure if there is any such loop, if this is something you should expect. So what do you see here? Is this a typical anatomy or atypical anatomy?
Atypical
Why?
because both nodes are almost together. There's no artery in between usually.
You said typical or atypical? You said typical, right?
No, atypical.
It looks like the anatomy you described, ma'am. Raika is passing behind it, and then anterior superiorly, and then in between the
Okay,
two
so
nerves.
the AICA in itself,
Typical problem.
the position of AICA in itself is typical here because it is looping outside the nerves. What is atypical? Somebody has mentioned in the chat box, and they are
This
mostly right.
is causing the compression, I think, over the seventh nerve complex,
That's
and
right.
maybe the patient will have a hemianophaseal spasm because the nerve seems to be kinked.
That's right. You can see this innominate artery, innominate branch rising from the AICA, which is denting the seventh nerve. You can see the seventh nerve is slightly stretched around it, and patient might very well have hemifacial spasm. Very good of you to pick this on. Otherwise, if you're only looking at the position of AICA, the position is in itself the typical position. And let's look at, okay, I probably did not include any other image. Is that clear, or does anybody want me to go over it again?
Is this the way AICA is always found, the typical way? Because here in this image, it's not the AICA which is coming in between the two nerves. It is one of its branches coming in between.
That's right. That is why I said that AICA is perfectly fine. It's at its normal position. If you see, this is the facial nerve. This is the vestibulocochlear nerve, and what AICA is doing is which segment is this, by the way?
Meatal, ma'am.
That's right.
Cisternal.
This is the metal
Cistern-
segment. This one.
Meatal segment, yeah.
So this is the metal segment, and there is a loop. But the loop is at its natural position. The loop is posterior and inferior to the nerve complex. What you see here, this branch, this is a branch arising from the AICA. It's not AICA itself. So this is a variation in anatomy. For the position of AICA, the position is perfectly fine. So you're right, Dr. Ajay. Let's move to the Chavda classification. We did discuss Chavda classification briefly. There are three types. We have
Yes, ma'am.
type 1, we have type 2, we have type 3. And since we have discussed the segments of AICA, it would be a lot easier to understand the Chavda classification now. I am audible, right?
It's too clear, ma'am.
Okay. So type 1 is cisternal, type 2 is porous, type 3 is intracanalicular. If you only remember the names, you would easily understand what is meant by each type. Cisternal means it is only traveling within the CPA cistern. It is not entering the internal acoustic canal, internal acoustic meatus. When we say porous is type 2. It is entering the internal auditory canal, but occupies less than 50%. And then when we talk about type 3, it goes all the way inside the canal and then comes out, completing this loop within the canal. And why is that a problem? It is a problem because when you're drilling the internal auditory canal, which you would eventually do, if you want to do a complete resection of the vestibular schwannoma, you would have to drill open the internal auditory canal. Once you drill that open and you are unaware that it is a type 3 loop, it is a type 3 classification, you would be able to, inadvertently damage AICA. Let's look at this illustration. Let me see. This is our normal anatomy, and this is our normal anatomy as well. There's a prominent loop in this first image. There is no loop as such in the image that you saw above. Both are type 1. What is happening is it is not entering the internal acoustic canal. When you look at type 2, you can see that this is entering inside. It's going inside the internal auditory canal, but let me mark the length of the canal. This is the length of the canal, assuming, for example, this is half. This is half. Then this stays within the first half. It does not extend beyond the first half of the length of the internal auditory canal. Is that clear? Does anybody have any problem with this concept? It enters the canal, but it does not reach all the way. And what is our cutoff? Our cutoff is 50% of the length of the internal auditory canal. Type 3 is when it is traveling more than 50%, even if it does not reach the end of the internal auditory canal. If it is extending more than 50% of the length, then it is a type 3. What is going to happen is we drill this portion. Let me mark. We are going to drill this portion roughly. When we are drilling this, can you see how easily it is possible to damage AICA here if you're drilling it? Clear. move on. This is another illustration. Boring, probably more simplified than the previous one, but easier to understand. You can see type 1, where it is reaching the acoustic meatus, but it's not entering inside. Type 2, where it is traversing the internal acoustic canal, but only less than 50%. And type 3, where the travel is more than 50%. Okay, this is the second vascular structure I want all of you to be very clear about. Dandy's vein complex. Can somebody tell me what is Dandy's vein complex? Anybody? You can cheat now. I am audible, right? Am I audible?
Yes, you're audible, ma'am.
Yes, ma'am. Audible, ma'am. Audible.
Okay. Okay, Dr. Ajay is asking, AICA traverses between the two nerves and metal part. Depends. AICA has variable anatomy. We did the loops before. The normal position is posterior inferior. It does not traverse between the two nerves. The interneural loop is an anomaly. It is a variation. What do I mean by interneural? What you are asking me, this would be interneural AICA traveling between the two nerves. This is a variation. This is not its normal position. The normal position is going to look like this. Is that clear, Dr. Ajay? Okay. Let's move on. So we have superior petrosal vein or the Dandy's vein complex. Dandy's vein is something, first a clarification, a very quick clarification. Superior petrosal vein and superior petrosal sinus, they are not the same thing. A sinus is it's a bigger structure, and superior petrosal vein is one of its tributaries, which drains 3 other veins. So these are not the same structure. Superior petrosal vein and superior petrosal sinus. So let's get this out of the way if for anybody who did not know this. Apart from this, why is it important? Because this is going to be near our superior end of the field. It's not a single vein. It's a complex. There is going to be transverse pontine vein. There's going to be vein of the cerebellopontine fissure, and there's going to be cerebellomedullary veins. So 3 veins that you need to know. Transverse pontine vein, we have the vein of the CP fissure, and we have the cerebellomedullary vein. Please note that this is not the vein of the cerebellomedullary fissure. That is a different vein. These are smaller cerebellomedullary veins, right? 3 structures. And let's look at this image. The Dandy's vein or the superior petrosal vein is near the 5th nerve. Because it's near the 5th nerve, it's at the superior end of our operative field while we are doing the retrosigmoid approach near the tentorium, right? So we have 3 veins. We have the transverse pontine vein, we have the CP fissure vein, and we have the cerebellomedullary fissure something. I completely forget these names. Cerebellomedullary veins. If we look at this, you can now see, you would have to imagine that this orientation is lateral. The stent here is our superior end. This is our superior end. And this is our cranial nerve 7 and 8 complex. This is our 5th complex. And where's the surgeon? The surgeon is standing on this side, retracting the cerebellum and looking at it. So this is the superior end of your field. Is everyone clear about the orientation?
Yes, ma'am.
Okay. So what ends up happening is, sometimes when we are doing the retrosigmoid approach, Or when we are doing microvascular decompression for trigeminal neuralgia, Dandy's vein can block our view. This is a very controversial structure in terms of preserving or sacrificing. Different surgeons, different authors have different beliefs and different experiences as well. There are surgeons, and I have seen some of my seniors sacrificing the superior petrosal vein without any consequence to the patient, but literature says otherwise. And because we are here to see the literature, in the literature, superior petrosal vein is mostly not considered a sacrificable structure. You are going to save it as much as you can, because if you end up sacrificing it, there can be venous infarction in brainstem in critical areas, which will be life-threatening. This is a debate of its own. And I think there are a lot of papers. They are very interesting papers. I would recommend to read. And I'll see if I can leave a few links on the group as well. And let's look at another image. Let me mark. So this is our superior petrosal vein. And then we have the cerebellopontine fissure. Let's see, where are our other veins? We have the transverse pontine vein. And I can't see the cerebellomedullary veins here, but there are smaller tributaries. So these make up the trunk of the Tandy's vein complex or superior petrosal vein, which then ends up into the superior petrosal sinus, draining into it. Now, if you look at it, it's not going to be much of a problem during the retrosigmoid approach, but if you're doing MVD, it can be a difficult structure to preserve, because now it is directly in the field of vision. You can see that its tributaries are coming in front of the trigeminal nerve. What ends up happening is sometimes when there is a huge tumor around this region, let's assume when there is a vestibular schwannoma and this entire area is stretched, then there can be problems during retraction. So I have seen a few of my seniors sacrificing it, but without any deficit. This is the anatomical image. It's cadaveric. The second is the endoscopic. And you can look at the views here. Let me mark. You can see the vein of the cerebropontine fissure. And you can see it going away. On the endoscopic view, you can see how beautiful this is. The fifth nerve is completely hidden and behind the Tandy's vein complex, but the seventh and eighth are visible. So when you're operating, it is around the superior end of your surgical field. What is the structure here? Right around it? Since it's the superior end.
Third cranial nerve.
Sorry? Look at it again. It's fibrous.
Third cranial. It's arachnoid.
That's tentorial margin.
I don't know. I think I cannot hear
The
what
tentorial
all of you are
edge.
trying to say. Probably my internet acting up. Okay, that's okay. We are. Yes, it's. Did somebody say tentorium?
Yes, ma'am.
Tentorial edge, yes.
Okay, I'm sorry if anybody else said it before. I could not hear it, but this is tent. You can take a look at the image D here, and the tent is completely visible. And that is why I keep mentioning that this is the superior end of our surgical field. Is that clear?
Yes, ma'am. Yes, ma'am.
Okay, let's move on. I think that's it. Probably the second last slide or the last slide. You can see in this image how beautifully it is crossing the fifth nerve and how big of a problem this would be to the operating surgeon who is trying to do an MVD, because now it is crossing completely in front of the fifth cranial nerve. Usually, a lot of surgeons use this nerve as a landmark in terms of identifying the fifth nerve. Why? We have discussed this in the previous session. Once you are in the CP cistern, the space is very narrow, and when you retract the cerebellum, usually you see some nerves on top. On top, I mean very easily visible. And those nerves are not fifth nerve, they are complex, they are seventh and eighth nerve. For the fifth nerve, you have to retract slightly superiorly, and you also have to go deeper. And superior petrosal vein can serve as a very good landmark in order to identify the fifth nerve. And yes, we discussed this retrosigmoid approach. Even if you are doing it for microvascular decompression, or you're doing it for vestibular schwannoma, it can compromise your view, but it's better to work around it instead of sacrificing it because you are not 100% sure about how the patient would behave afterwards. And how do we know what investigations to get before proceeding for a retrosigmoid approach? Ideally you should have a cis or FISTA sequence, and sometimes if you find any anatomical variation in these, then it's wise to get a CTA, and then you would need a CT temporal bone. And in the centers that have this option, then MRI TOF, time of flight, that is also a good option, because all these sequences, what they are going to do, they are going to delineate this particular neurovascular anatomy that we have discussed. Without knowing this, operating on a patient for vestibular schwannoma via retrosigmoid approach is going to land both you and the patient in the problems, and the outcome is not going to be as good as it looks and sounds in the textbook. Have I made myself clear?
Yes, ma'am. Yes, ma'am.
Okay. Let me see. Okay, so this is our last slide, the slide that I was talking about. This is a cheat sheet for anybody who wants to remember and keeps forgetting this stuff, or for people who have exams, clinicals coming up. Facial nerve is anterior or anterior superior, right? And once you are doing the vestibular schwannoma surgery, then facial nerve is going to be right at the anterior end of the tumor capsule. You're not going to see it first. Apart from that, what are you going to find? Anterior inferiorly, we are going to find the cochlear nerve, because the vestibular schwannoma, as apparent from the name, it is usually involving the vestibular nerve, the vestibular segment. Cochlear nerve is going to get pushed inferiorly. Sometimes anterior inferiorly, mostly inferiorly. Usually, you're also going to find the main loop of AICA here as well. AICA's main loop can be inferior, can be anterior inferior, and can be posterior inferior as well. Posterior inferior is more common, around 70 to 80%. In rest of the subjects, it can be anterior inferior. Is it making sense? Or is it too fast? We have discussed all of this. This is just a review.
It's okay, ma'am.
Okay. So we know that if we end up sacrificing AICA or cochlear nerve, in either case, if we sacrifice AICA, patient is going to have a cerebellar stroke. If we end up sacrificing cochlear nerve, there will be complete hearing loss. If we only sacrifice labyrinthine artery, there will be acute hearing loss as well. So apart from that, let me see, what do we have on the superior end? On the superior end, we are going to have trigeminal nerve and the Dandy's vein tributaries. They can be three very visible trunks, and they can be a single vein which is driving its tributaries more proximally. It depends on that patient's anatomy. Dandy's vein is not sacrificable. As much as I have read, people have sacrificed it with variable experiences, but ideally you should avoid it. You should try to preserve it as much as you can. And then you have trigeminal nerve. Trigeminal nerve is less of a problem during vestibular schwannoma surgery, until and unless the tumor is so huge that it is now causing symptoms like facial numbness, etc., etc. Usually it stays away at the superior end. Apart from that, inferiorly, we know we have our lower cranial nerves, the most dreaded complication of CPA angle surgery. You do not want to damage lower cranial nerves. You do not want to imagine lower cranial nerves as the 7th and 8th nerve complex, because they can sometimes look very similar. So be very, very, very careful. Posterior fossa is very unforgiving. Apart from that, posteriorly, immediately we have the flocculus and the cerebellar veins. Cerebellum is forgiving, but sometimes patient can present with personality changes and posterior fossa syndrome if you're not careful with your retraction. So that's it for today. We will call it a day. This is a wrap. Let me know if there are any questions that I have not taken during the live session. You can leave them on the WhatsApp. This is a wrap for today.
Which segment of trigeminal now, ma'am?
Sorry?
The trigeminal now,
Mm-hmm.
which segment is V1, V2 or V3 or the?
No. When we're talking about trigeminal nerve, we are talking before it is dividing into V1, V2, and V3. Where does it get divided into V1, V2, and V3?
At Meckel's cave, after Meckel's cave.
Yes, so we are far away from that. Let me go back. Let's go back. This is a very important concept. Let me see if I have that. Yes. So this is our V5. And this is a single trunk, right? The single trunk is then going inside the Meckel's cave, making this Gazarian ganglion, and then there are these 3 branches. But this happens after it leaves the cistern.
Okay.
Is that clear?
Yeah, yes.
So none of this is visible while we are working in the CP angle cistern. For CP angle, the only part we are concerned about is the cisternal component. You don't see these branches. These are inside the Meckel's cave, and you won't be able to access Meckel's cave because it's going to be at the tip of the temporal bone, right here. Where are we working? We are working in this region. Is that clear?
Yes, ma'am, yes. Thank you.
And even if you are doing MVD and you are retracting the cerebellum superiorly, you're looking at 5th nerve. Where would this end? This would end right at this sleeve. There will be a particular dural sleeve. The 5th nerve will penetrate the dura, and then you won't be able to see Meckel's cave outright. I think there was an image which was demonstrating this. Let's take a look. If you take a look here, and this is the view you're going to get during the retrosigmoid approach. It's going to penetrate dura, and then the Meckel's cave is going to be right behind it. You will not be able to see it. Is that clear? Okay,
Yes,
so this is going to be our view. I think you missed the first 2 sessions because we did cover this anatomy. This is going to be our view. We are going to look at the main trunk. The Meckel's cave is going to be way, way inside. Thank you so much, everyone. That's a wrap. And Dr. Ajay, let me check my schedule because I have scheduled the first 3 days of the week for the live Zoom sessions. Let me see if we have a free day, then we can do it. Otherwise, we would continue from Monday, inshallah.
Hello.
Thank you so much, everyone.
Hello.
Yeah.
I've got a question. I wanted to ask specifically about the vein that you mentioned called the cerebellomedullary vein. Does it have another name? I'm struggling to remember if I've come across it before.
I am not aware of any other name. If someone else is, they can always mention it in the chat box or on the WhatsApp group, or I can check it and let you know.
Okay, thank you.
Thank you. Thank you so much, everyone. That's a wrap for today.